In this section, we discuss the use of a fenestrated pencil point needle for proximal saphenous nerve block. As we have mentioned earlier, there are a number of techniques that can be used to perform most blocks. This needle is one more tool that can be used in selected cases. The fenestrated needle used for the proximal saphenous nerve block in this section has a pencil point design and centimeter markings along the shaft. The distal 2 centimeters of the needle has side ports on alternating sides of the shaft at 1 millimeter intervals. The outflow pattern during injection is displayed here. If we review the anatomy of the adductor canal, we see that the distal border of the adductor canal is defined by the insertion of the adductor tendon, as well as the passage of the femoral artery through the adductor hiatus into the popliteal space. The saphenous nerve passes superficial to the adductor tendon into a tissue plane between the vastus medialis and sartorius before diving deep to the pes anserinus. The point where the saphenous nerve passes over the adductor tendon actually defines a transition point between the true adductor canal and simply the tissue plane between the vastus medialis and sartorius muscles. Blocking the nerve proximal to the insertion of the adductor tendon is a true adductor canal block, whereas injection distal to this point is simply an injection of the saphenous nerve in the tissue plane between the vastus medialis and sartorius muscles. In this diagram, an axial ultrasound view of the distal thigh is represented. The ultrasound transducer is positioned over the medial aspect of the right thigh at the level of the superior pole of the patella. In this view, the tissue plane between the sartorius and vastus medialis is represented with the adductor tendon present as a hyperechoic structure. The adductor tendon is almost always visible at this level and is frequently mistaken for the saphenous nerve. The position of the saphenous nerve is represented in this drawing, however, in actuality, it is rarely visualized at this level. When blocking the saphenous nerve at this level, it can be difficult to define whether the injection is occurring within the investing fascia of the sartorius muscle, within the investing fascia of the vastus medialis muscle, or actually in the tissue plane between these two muscles. For example, in this injection, the needle tip is positioned within the investing fascia of the sartorius muscle. This injection will be ineffective. This diagram represents the distribution of injectate when the fenestrated needle is passed across the tissue plane separating the vastus medialis and the sartorius at the level of the superior pole of the patella. Outflow from side ports along the distal 2 centimeters of the needle distribute drug within the tissue plane between these two muscles as well as within the adjacent tissue on both sides. During this actual in-plane approach, there is tenting of the fascia as the pencil point needle crosses the tissue plane between the vastus medialis and sartorius muscles. This gives the operator visual and tactile feedback as the needle crosses the targeted tissue plane. With injection of a 20 ml volume of local anesthetic, there is visible hypoechoic distribution along the distal 2 centimeters of the needle, which extends into the adjacent sartorius and vastus medialis muscles. An interesting observation after injection with the fenestrated needle across the tissue plane between the vastus medialis and sartorius at the level of the superior pole of the patella is that the sensory changes produced resemble those produced after a more proximal injection within the adductor canal. A possible explanation for this finding may be sensory nerves that exit the adductor canal and travel in adjacent tissues as shown in this dissection. This diagram shows how these nerves may be positioned within the sartorius and vastus medialis muscles. This is a simultaneous video of the surface and ultrasound view as a fenestrated needle is advanced across the tissue plane between the vastus medialis and sartorius at the level of the superior pole of the patella. In this particular case, the pencil point needle with the 2 centimeter fenestrated tip is advanced through an introducer on the lateral side of the ultrasound probe. As the needle is advanced, there is tenting first of the investing fascia of the leg and then of the fascial plane between the vastus medialis and sartorius. This gives visual and tactile feedback to the position of the needle. During injection, distribution of local anesthetic is evidenced by hypoechoic areas in the plane between the sartorius and vastus as well as throughout the adjacent tissue on both sides of this tissue plane. The fenestrated needle is one more tool that can be used in conjunction with ultrasound as needed to perform lower extremity nerve blocks. Thank you.